Good evening, everyone, from different parts of Africa. Good morning or good afternoon, and welcome to our ILAE Africa webinar. Today, we have a very amazing topic on epilepsy surgery. And my name is Dr. Faith Mosha. I'm a pediatric neurologist, and I would like to introduce our speaker for today, who is Dr. Melody Asukile. She is one of Zambia's first Zambian neurologists. She completed neurology residency in 2020 at the University of Cape Town in South Africa. She further specialized in clinical epileptology there, and which was funded by an education award from the International Federation of Clinical Neurophysiology. She's a lecturer and an attending neurologist at the University Teaching Hospital in Lusaka. She also directs the National Electroencephalography Laboratory, and her research interests include epilepsy diagnosis and management in resource-limited settings and the use of telemedicine for neurology education and service provision. So it is my pleasure to welcome you, Melody, and to welcome you all. If you have any questions, please post them in the Q&A question box during the presentation session, and we'll address them after the presentation. Thank you. Welcome, Melody.
Thank you very much, Faith. And thank you once again to ILAE Africa for giving me this opportunity to share. Should I go right ahead and start?
Yes, you can proceed.
All right, thanks. Okay, can you see the slides?
Yes, we can see the slides.
All right. Okay, great. Thank you. So hi again, everyone. I'm Melody Asukile, as Faith mentioned. And today I'll be sharing some thoughts on the implementation of epilepsy surgery in Sub-Saharan Africa. So I have no disclosures relevant to this talk. And this is a brief outline of some of the things that we're going to discuss today. So starting with the burden of epilepsy, I think this is not strange to any of us to mention that epilepsy is one of the most prevalent neurologic disorders, and it affects over 50 million people worldwide. It is a leading cause of disability associated with a neurologic disorder. I think, as we all know on this call as well, is that the burden of epilepsy is highest in resource-limited settings, particularly in Sub-Saharan Africa. And almost over 80% of these 50 million people living with epilepsy are in low and middle income countries. The thing as well with epilepsy in low and middle income countries is there are many factors that are risks for epilepsy that are potentially preventable. And these are high cases of head trauma, central nervous system infections, and perinatal brain injury. So what about the epilepsy treatment gap? We know the burden of epilepsy is highest in Africa. And at the same time, the treatment gap is highest in Africa. So generally, when we think about epilepsy, up to 70% of people with epilepsy who are adequately and appropriately treated with medication can be seizure-free. Of course, on the other side, that means that there is still a 30% who do not respond to treatment, and these are said to have drug-resistant epilepsy. In Africa, over 80% of people with epilepsy do not know their diagnosis. So they don't know that they have epilepsy. And when they do, they don't have access to the appropriate treatment. So we are faced with a double challenge, which is one of not knowing when we can make a diagnosis of drug-resistant epilepsy, because you'd have to have given someone a good trial of at least 2 medications and 2 appropriate medications for you to say they're drug-resistant. So in the first case, those who do get diagnosed might not get that adequate trial medication for us to really say if they're drug-resistant or not. And then secondly, many will become drug-resistant on just the drugs that we have available because access to drugs may be quite limited. And further, this epilepsy treatment gap is widened by other factors like cultural factors where there's lots of stigma and myths about epilepsy, and this further compounds our access to care. So what's the rationale for epilepsy surgery? Epilepsy surgery in itself is a procedure which involves resection of part of the brain that is identified as containing an epileptic focus or an epileptogenic zone. So it's typically used for treatment of drug-resistant focal epilepsy because it starts with identifying an area where the seizures are coming from. So for certain types of epilepsy, and particularly temporal epilepsy with hippocampal sclerosis, which has been studied quite widely, up to 70% of patients can become seizure-free. And this means that their epilepsy can be cured. These procedures, though not so complicated, are greatly underutilized in low and middle income countries. I think this is already stemming from the history of poor understanding of epilepsy in our setting. There is poor patient and also physician understanding. Certain surveys have been done globally talking to physicians or asking physicians, what are your perceptions about epilepsy surgery? And many will say they don't know about it, and those who do may not really have faith in the procedure. And so at the same time, that means that trickling down to patients, that access is limited. But of course, it's not just about knowledge, it's about disparities in access. Where do you find an epilepsy surgery program in Africa? There are few trained personnel, and the cost, especially perhaps say setting up such a program, can be quite high, and so there's limited access in our setting. What is of interest, though, is several studies, including a recent one in Kenya by my colleague Kariuki et al., have shown that majority of epilepsy in Sub-Saharan Africa is likely structural. And that actually gives us insights into thoughts that perhaps a procedure that can take away that structural abnormality may be quite beneficial in our setting. I think what would also be really interesting and useful is that if we had a treatment for epilepsy that's potentially curative, perhaps we can overcome certain hurdles like access to medications, which patients have to take frequently. When we replace it with a treatment that is probably once off and may greatly reduce or even cure seizure frequency. So this is something to really think about. Is there a role for epilepsy surgery in low resource settings? So usually epilepsy surgery involves what's called a pre-surgical evaluation. And this perhaps may also come into thinking about the cost for epilepsy surgery. So typically a team of, an epilepsy surgery team will comprise neurologists, there will be neurosurgeons who actually perform the operation, radiologists who look at the imaging, neuropsychologists, the EEG technologists, and nurses. And this always begins with a selection of a patient with epilepsy who has drug-resistant focal epilepsy. And then there's EEGs involved. So EEGs come in different forms, and the most common ones that we see and that we know of is the routine scalp EEG, which is done for 20 or 30 minutes. But usually when you're evaluating a patient for epilepsy surgery, we usually employ a long-term video EEG. So at minimum 24 hours or longer, where you monitor the patient looking for evidence of that epileptic focus. So these are discharges, abnormal discharges that we see on the EEG, and often we're actually looking for a seizure on the EEG to try and determine where the problem is. In more specialized centers, the EEG can be more sophisticated, and it can include an intracranial EEG. So instead of placing the little electrodes or the little plates on the scalp, an incision is actually made or a craniotomy is made into, and the electrodes are placed inside the cranium, and these can be subdural or they can be depth electrodes. Another important aspect of pre-surgical evaluation is brain imaging. So in most centers, typically at the very least, they'll use an MRI, but I will share some studies where they've looked at using CT scan, for example. And then other more specialized functional imaging like FDG PET and SPECT or functional MRI may be employed. And often neuropsychological assessment is encouraged. And this is because, as we all know, that epilepsy tends to come with comorbid mood disorders and at times even cognitive disorders. And so it's important to have an understanding of where your patient sits prior to your epilepsy surgery. And though having a qualified neuropsychologist is beneficial, using even employing psychiatrists, for example, or psychologists who might not necessarily be specialized in neuropsychology could still be useful. And then with all this, it is very important that there is appropriate infrastructure in place and there is administrative support for such a program. So I'll start by talking about some experiences of epilepsy surgery in Africa. This won't be exhaustive really, but I just thought I could highlight a few cases of epilepsy surgery that we've seen in our continent and what their outcomes were. So the first one I'll talk about is actually a recent publication from colleagues in Morocco who talked about their experience of epilepsy surgery over a 16-year period. So this is fairly recent, between 2005 and 2021, and they reviewed 132 cases. It was a retrospective study. So of note in this study, all their patients underwent video EEG monitoring, so no intracranial monitoring was done. And as you see, as I mentioned, temporal lobe, you see this in many epilepsy surgery programs, that temporal lobe surgery is the most common type of surgery performed in almost 90%. And they did have a few who had extratemporal surgery. Their cohort was quite young, with a median age at surgery of about 24 years. And they looked at short-term outcomes at a period of 3 months. So what they found is that at 3 months post-surgery, about 90% was seizure-free for those who had temporal lobe epilepsy, and slightly lower for those who had extratemporal lobe surgery. So that's surgery outside the temporal lobe. And so I think in conclusion from this study, they noted that they didn't use very sophisticated pre-surgical evaluation techniques, and also they conducted predominantly what would be considered a relatively simple, I would say, procedure of temporal lobectomy. And so low-cost mechanisms or low-cost strategies proved beneficial in the short term. Another study I'll refer to, slightly a few years longer than the other one, was a pilot study of epilepsy surgery in Uganda. So I thought to highlight this study, though it's been quite some time when they did it, but I highlighted because they employed even lower cost measures as they employed epilepsy surgery. So given that their resources were really limited, they really focused on just temporal lobe epilepsy cases, the type of surgery or type of epilepsy that has been identified to respond very well to epilepsy surgery. In this instance, they used CT scans only, but they did try to enhance the CT scans, and they did really thin slices to help them identify lesions. And then what they also did in this case is they didn't have neurologists on site, but nurses were trained on how to apply the EEG electrodes and how to acquire the EEGs. Then the EEGs were analyzed remotely by physicians, I think in the US and in Canada. And further on, they didn't have specialized neuropsychologists, but nurses were trained in how to conduct a modified mini-mental state exam, particularly adapted to that setting. And so they used that as a way of screening for some cognitive and also some mood disorders in their patients pre-surgery. They screened 49 people, and because they had to be very selective in their patients, 10 patients of those were selected for surgery. And it was noted as well, I think as we've been learning more and more as we do studies in Africa, 49% had a history of cerebral malaria. So there was an insult to the brain that led to this temporal lobe epilepsy, or at least that was associated, I would say, with the temporal lobe epilepsy. They looked at outcomes at about a year after surgery, and they noted that 6 of those 10 patients were seizure-free, so they were no longer having seizures. 2 of the patients had more than 90% reduction in seizure frequency. And then the other 2 had the same frequency of seizures, but the severity was reduced. So they also concluded that low-cost solutions, as I described, can be beneficial when you select patients appropriately, and they can result in good outcomes. So finally, what I would like to do over probably the next 20 minutes or so is just talk about the experience of epilepsy surgery in South Africa. So this is the characteristics and outcomes of adult epilepsy surgery patients in Cape Town, South Africa. And it's a retrospective study that we did looking at a long-standing epilepsy surgery program. These are some of my co-authors listed here, who I'm very grateful for their contributions. So the objective of our study was to determine long-term seizure freedom and quality of life-related outcomes of epilepsy surgery patients in South Africa. This was a retrospective cohort study, and it also included a prospective quality of life outcome survey of adults who underwent epilepsy surgery between July 2007 and July 2022. So over a 15-year period, and it was at a privately owned hospital in Cape Town, South Africa. So over this 15-year period, 602 surgeries were performed. However, we analyzed 375 based on those who were adults and that they had an initial epilepsy surgery at this hospital, Constantia Begmedi Clinic. And also we were reviewing electronic records, and so those who did not have sufficient records would also be excluded. For the prospective components, we had 211 patients who you could reach out of the 375 for this post-surgery survey. So this is just a figure showing how the patients were selected. And to the left here, I've just highlighted what the epilepsy surgery team comprised. So as you can see, it comprised 1 neurologist, 1 neurosurgeon, 1 neuropsychologist, 2 EEG technologists, and ward nurses who were working on a combined neurology neurosurgery ward, and there were 5 monitoring beds available. So of all these patients, as I mentioned, several were excluded for various reasons, and then we had 375 participants in the end. We analyzed those based on whether they had temporal lobe epilepsy surgery or whether they had extra temporal lobe epilepsy surgery, so surgery outside the temporal lobe. Those who had temporal lobe epilepsy surgery, we then looked at the ones who had an anterior or a temporal lobectomy, and then we looked at those who had a procedure that's called a selective amygdalohippocampectomy, quite a mouthful. But this is where you actually, instead of taking out the whole temporal lobe, the whole anterior temporal lobe, you actually just take out a section of the medial part of the temporal lobe, which is essentially this, the amygdala and the hippocampus. So there's been studies about that, and so certain surgeons may choose to do this procedure as opposed to a more holistic anterior temporal lobectomy. And then in the extratemporal lobe epilepsy surgery group, some patients had structural lesions removed, for example, tumors or vascular malformations. There were some who were thought to have, say, cortical malformations, for example, and they would have a more extensive lobectomy or cortical resection. And then some more palliative surgeries like callosotomies and hemispherotomies. So this is quite a busy slide, but these are some of the baseline characteristics. And as I mentioned earlier, dividing into those who had temporal lobe epilepsy surgery and extratemporal lobe epilepsy surgery. So of note, when you just look at the ages, we noted that those who were having surgery for extratemporal lobe epilepsy surgery were significantly younger than those who were having temporal lobe epilepsy surgery. But it also goes to the diagnosis. So it was more likely that if a patient had temporal lobe epilepsy surgery, their diagnosis was later than one who had extratemporal lobe epilepsy surgery. I'll call them TLE and ETLE, just to make it simpler. We found that time between diagnosis and surgery was quite long for both groups, so about 15 to 17 years, and there was no difference between the two. No significant differences with regards to female sex, though for some reason the TLE group were more likely to be female. Education level and employment levels were better in the TLE group. That could be a function of age and also some other factors that I'll talk about shortly. And then looking at their pre-surgical epilepsy history, so we see that focal unaware seizures were more common in the temporal lobe epilepsy group, whereas more severe seizure types like focal to bilateral tonic-clonic or generalized tonic-clonic were more likely to occur in the extratemporal group. Further, we see that those in the extratemporal group had tended to have more seizures per month. They tended to be on more medication. So it was more likely that the extratemporal group had a more severe epilepsy problem compared to the TLE group, and perhaps you wonder if that could have led to some of the delays in the diagnosis and in the presentation. So for our cohort, this was the pre-surgical evaluation that was employed. So this center at the Constantia Bergmedi Clinic with the neurologist, Dr. James Butler, is considered in the country and perhaps even in the region as an epilepsy center of excellence. And so many patients who were coming to see Dr. Butler for epilepsy surgery evaluation were those who had probably been seen by other doctors and had already had their routine EEGs and were actually coming for evaluation if they were candidates for epilepsy surgery. So often we would forego the routine EEGs and proceed to a more long-term EEG, which was the video EEG. So all patients had video EEG, and the monitoring varied in duration, but it was a median of 7 days. All patients also had an MRI. They all presented and had at least a 1.5 Tesla brain MRI. About 27% of this group also had a functional MRI. For some patients, 44% to be specific, there was invasive monitoring involved. And again, this wasn't the complex invasive monitoring, but invasive monitoring with subdural electrodes. And those patients who did get intracranial EEG had a median of 8 days of monitoring. So you can see for some patients, monitoring could be as long as 2 weeks because typically you would start with a video EEG, and then if it's inconclusive, you would proceed on to get an intracranial monitoring, or in the goal of trying to identify where the seizures are coming from and essentially trying to identify which is the epileptic focus. Almost 80% of patients had neuropsychological assessment with the neuropsychologist I mentioned. And we had really almost no one who had advanced imaging like FDG, PET, and SPEC, just about 1%. So for outcome measures, we looked at outcomes in two ways. We looked at outcomes with regards to seizure outcome, and then we also looked at outcomes in terms of patient-reported outcomes. So for the seizure outcomes, we used the ILAE seizure outcome classification. And so this was proposed, well, looks like 20 years ago now, time really flies. But this was a modification of the previous classification, which used to be called the Engel classification. So this classification was thought to be a bit more clearer with regards to the outcomes that you're looking at. And so class 1 with the ILAE classification is where someone is completely seizure-free. So they have no auras, no feeling that the seizure is coming. In class 2, they may get auras. So if you remember with focal aware or focal impaired awareness seizures, patients may have this warning or feeling that they're getting a seizure, which can be cognitive, autonomic, sensory, and so on. So they could get those, but they have no other seizures. Then class 3 is where they would get 1 to 3 seizure days per year with or without auras. And then the frequency increases thereafter for class 4, class 5, and really class 5 and 6 means that you haven't had much benefit from epilepsy surgery. So this seizure outcome classification was to assess outcomes of seizure freedom. So for our study, we considered class 1 and 2 as being seizure-free. That is, if you are having no seizures at all, or if all you're getting are those, say, focal aware aura type of seizures. So what did our outcomes show? So this is an overall of the ILAE seizure outcomes, and this figure just shows the percentage of participants who were at a certain class at a certain time. And so you can see that at follow-up 1, about 70% were class 1 or 2. Maybe also I should just give clarity as what to follow-up 1, 2, and 3 were. So follow-up 1, we looked at outcomes in the first year of surgery. So within 12 months after epilepsy surgery. Then follow-up 2 was up to 2 years after epilepsy surgery, so up to 24 months. So between 1 year and 24 months. And then follow-up 3 was beyond 2 years, so after 2 years of epilepsy surgery. And also just to remind everyone that this was a retrospective study, so we were looking at hospital records to determine these time points. So that means that there wasn't a set time. It wasn't that everyone was seen at the same time, but it was over that time period. And so over the first year, what was the outcome over the 1 to 2 years and beyond 2 years? So what we noted, though, is that, as I mentioned, at follow-up 1, 70% were seizure-free. At follow-up 2, that actually dropped down to about 55%, and at follow-up 3, about 52%. So not much a difference between 2 and 3, but you do see quite a drop between year 1 and year 2. And that also speaks to why it's really important to follow our patients in the long term. However, I do hope that you can appreciate, though, that despite perhaps a drop in the class of seizure freedom, it is still weighing higher towards lower classes than towards higher classes, which does show that there's still some general improvement in the epilepsy, though those who would report a cure at the end, say after 2 years, is just about half of the cohort. We looked at the 2 groups, though. Is there a difference in outcomes between those who had temporal lobe epilepsy surgery and those who had extratemporal lobe epilepsy surgery? And you can see that the differences are quite dramatic. There's quite a spread out, because then you notice here that the percentage in the temporal lobe epilepsy groups is much higher or significantly higher than the extratemporal group, though they are all still ranging in the 50s and 60s range. But generally, there was a more likelihood for a sustained seizure freedom in those who had temporal lobe epilepsy surgery than those who had extratemporal lobe epilepsy surgery. So starting with here at 74%, and then it drops down to about 54% beyond 2 years. Whereas in the extratemporal group, it's about 56%, and then dropping down to about 45% beyond 2 years. So another question we asked, though, is, quite all right, we've got seizure outcome classification, but what about the frequency of seizures? So do we notice a reduction in seizure frequency over time? So what we see here in the first column is the baseline seizure frequency. And you can see that in the beginning, quite a big proportion of patients were having seizures at least once a week, that's orange, or every day, that's in the blue. But you see that in the first year of follow-up, that drops significantly. And what we see throughout is a trend of reduced seizure frequency. So we see that patients then have seizures maybe just at least once a year or at least once a month, and there's very little having seizures once a week and every day. So the trend, again, is generally with reduced seizure frequency, and that seems to maintain over time. So the other thing we wanted to ask ourselves, or we looked at, was, are there factors that can predict a seizure-free outcome after surgery in our cohort? So it was really interesting because we found that only the total number of anti-seizure medication ever used was associated with a reduced likelihood of a good outcome. So those who prior to surgery had used many anti-seizure medications were more likely to have a poorer outcome, meaning they wouldn't get a class 1 or 2, their class would be much higher. And I think this is probably intuitive, that those who are on more medications were more likely to have more severe epilepsy. And so their outcomes may have been lower, but we didn't necessarily see what was their class 3, 4, 5, because generally, as I mentioned, you did see a trend towards improvement, but looking at seizure freedom specifically, they were less likely to be seizure-free. Interestingly, we looked at other factors that we thought might be predictors of good outcome, and they were not associated. There was no association. So when the patient had the surgery, how long they'd had the surgery for, the type of surgery that was performed, the presence of an MRI lesion on the brain scan, how long they had their EEG monitoring for, and whether they ended at video EEG or progressed to intracranial monitoring we found some trends, but we could not find significant associations with these factors. So finally, this was our post-surgery patient survey, where, as I mentioned, we were able to contact about 211 of the 375. So this now is in real time, where we call the patients and we speak to them, and we had a structured questionnaire that we asked them. And this structured questionnaire looked at certain factors about their seizures, what their current ILAE class was, and also it asked certain questions about how they perceived their quality of life. So for the survey, it was answered at a median of almost 7 years post-surgery. So it's quite a long follow-up. And of all the patients, when we just asked them, are you having seizures or not? So about 40% did confirm having some form of seizures, but 62% were seizure-free. So you see again that there's a difference here. When we looked at our follow-up 3, we found that it was generally around 55%. But when we called patients, because some of these are patients who were no longer coming to the clinic. So after we made the calls and looked at this group, we found that the class was actually higher or lower, I would say ILAE class 1 or 2 at 62%. 78% of these patients reported that their seizures were better than before. And so this was the severity of the seizures and the frequency of seizures, that it was better than prior to surgery. Looking at for quality of life, we used a validated tool that's called the Quality of Life in Epilepsy 10 score. So it's a validated questionnaire. It actually originates from a longer questionnaire, the Quality of Life in Epilepsy 89, which was then abbreviated to the Quality of Life in Epilepsy 31. And now there is a shorter screening tool called the QOILAE 10 score. And so we use that just so that we're not on the phone with patients for hours and hours. And with this score, it ranges from about 1 to 5. So 1 is a very good score, meaning you perceive yourself to have a good quality of life. And 5 is when you think your quality of life is very bad. And there are many different questions which are asking about your energy levels, your social life, your work, if you're on medication, are the medications affecting you, and so on. And it comes up with a composite score. So what we found is that our median score was about 1.8, and you can see even our upper limit was about 2.5. So generally, most of our patients reported a good quality of life, and there was no difference between whether those who had temporal lobe epilepsy surgery or extratemporal lobe epilepsy surgery. Generally, they all reported a good quality of life. And then when we also asked just how they felt their overall quality of life was, again, the score was good at about 2, and no differences between the two groups. It was also interesting to note that many of our patients were actually still on anti-seizure medication, with only about 21% who were off all anti-seizure medications. But of course, some of the limitations we have to note is this is not our entire cohort, so there is still about 150 participants who we could not reach, and perhaps that might have an effect on some of these results. So coming to the discussion, I think one thing we can appreciate is that this is, to our knowledge anyway, the single largest review of epilepsy surgery cases in Africa. I think we can also appreciate that the outcomes after epilepsy surgery in a resource-limited country where you've got very limited staff that are performing this program are comparable to higher income countries. So some of these outcomes that I've shown are very similar to what higher income countries are showing, and recent reviews that we've had about epilepsy surgery programs. In our cohort, we see that seizure-free rates were highest in the first year of up to 70%, but they did tend to reduce over the years. There was a long interval between diagnosis and surgery, so 17 years, which is almost 20 years, of a patient living with epilepsy. And I think the challenges are the ones we've spoken about before. This center in Cape Town is probably one of 2 or 3 centers in the country that are running this program. And if we blow it out to Sub-Saharan Africa, it's probably one of the very few with a consistent epilepsy surgery program. So there's definitely lack of access to treatment like epilepsy surgery. There's limited knowledge about these procedures, which are not as complex as we might think, but people do not know that this is a treatment option that's available. I think I would like to highlight that another thing perhaps that I haven't brought out is the very low post-operative complication rates. So our rates, the rates of complication in this program were less than 9%, and they were often minor. It would be, there was a patient, I think, or two who had a CSF leak that was, that stopped spontaneously. There were some who would report an upper quadrant anopia. There were a few with transient word-finding difficulties, but there were no major complications and there were no deaths from this procedure. One thing I think that was also of interest and that probably requires more investigation analysis is that the identification of an MRI lesion was not a predictor of outcome. And this speaks to probably the likelihood of being very careful about selecting your patients. Because when you're such a small team and when you've got limited resources, you have to carefully select which patient you think is appropriate. And of course, you're selecting the patients who you think has a higher chance of a good outcome. And perhaps all these different considerations may play a role in determining outcome rather than whether that patient has a lesion on the MRI or not. And I think another thing that was quite unique about this study and that we should be thinking about more is asking our patients, how do they feel about this procedure? There is, of course, a bias that if you've gone through a surgery, you are very optimistic that it should have gone well, and so you may report that it's gone well. But talking to patients and getting their outcome, getting their thoughts, especially before surgery and after, has it made a difference to their quality of life? Do they think they have a good quality of life? And so I think that was something really important for us in this study. We are still analyzing data because some of our participants had quality of life assessments prior to surgery. And so we are going to compare the before and after if there was a significant change in their self-perceived quality of life. So in conclusion from this study, I think epilepsy surgery, as I've mentioned throughout this talk, is an underutilized resource in Africa. But what we demonstrate here is that a dedicated center with a single neurologist and neurosurgeon, appropriate infrastructure in place, could implement a program with patient numbers and outcomes like those in highly resourced settings. There are some limitations that we have to acknowledge, and that's that this was a retrospective study design. We got very few histopathology results from our study, so we don't have enough information to say what the pathological issues were, though we did report on a few of these. It is a single-center study, and that does come with biases of its own. And because of retrospective designs, we don't have standardized follow-up times. So the follow-ups were really dependent on what was done on a clinical basis. But as I mentioned, it's still quite a large study with large numbers in the African setting, and I hope we've learned some lessons from it. So just what are some take-home points and future directions? I think just to remind us, something that we all know is that the burden of epilepsy is high in Africa. There's an urgent need for us to think about therapies that are appropriate for our setting. And we should start thinking outside the box, particularly about potentially curative options, which could be beneficial in patients, say, who live in rural areas, don't have access to treatment. Could treatments such as epilepsy surgery be really good for a patient who might need very low dose anti-seizure medication or no anti-seizure medication at all? So we really need to think about prospective studies investigating some of these low-cost options. I mentioned how colleagues have looked at low costs like task sharing, task shifting. So getting other cadres, for example, like nurses, to do certain jobs maybe that an EEG technologist would do or that a psychologist would do, incorporating community health workers, using lower cost methods of EEG, lower cost methods of imaging, for example. So we need to think about improving diagnostics in our setting, How do we develop better clinical assessment tools? How can we think about more accessible imaging for our patients and electrophysiological tools? And where does the role of genetics come in as well as we investigate patients with epilepsy? I think one thing that's also potentially possible that we've seen, for example, if I refer to our neurology training program in Zambia, is how we are encouraging training of specialists in the region. So training of specialists where you see similar conditions, you are dealing with a similar demographic of patients. So we can think about regional hubs for training, for example, for epilepsy surgery and expansion of epilepsy surgery programs, because then we're dealing with similar situations, similar settings, and such programs then can be scalable when you learn from people within the region. So I hope as we think about all of this, it helps us really as we're aiming towards the IGAP, the Intersectoral Global Action Plan for epilepsy and other neurologic disorders, that we can aim to this point of 90% knowing their diagnosis, 80% having access to treatment, and this is medications, but including treatments like epilepsy surgery, so that we then reach this target of 70% of people who are free from seizures. Okay, thank you very much. I really just want to acknowledge my co-authors and supervisors, particularly my co-first author, Dr. Aisha Soning, who spent hours and hours looking through the folders. Dr. Butler, as I mentioned, is the neurologist who has seen all these 600 patients, and Prof. Lawrence Tucker, who's been my supervisor through the clinical fellowship at the University of Cape Town. Thanking the IFCN, my Zambian neurology team, who are always supportive through Prof. Diana Saylor, and ILAE Africa for always giving us this platform to share with colleagues. Thank you very much.
Thank you so much, Melody, for an amazing presentation. Really, really informative, and also just to make people aware that epilepsy surgery is actually one of the best options for our patients who have medically refractory seizures. So we have a few questions on the Q&A. And the first one is from Zamir Fakir, who asks, from your experience, what are the short and long-term outcomes associated with hemispherectomy in pediatric patients? Any idea?
Okay, thank you so much. So what you can see from our study, and probably I guess it will be study part 2, is we excluded about 150 patients from pediatrics who had epilepsy surgery. I think I just thought that's something that needs a bit more time, and perhaps consulting my pediatric colleagues before I delve into it, since I'm an adult neurologist. So I think I don't have numbers specifically. I know one thing that it does show is that there is a reduction in seizure frequency. And sometimes when we do hemispherectomies, callosotomies, we tend to call them palliative procedures. So this is in children who have really bad, really drug-resistant epilepsy. They're having seizures almost every day for hours a day. And these procedures help to reduce that seizure frequency. I can't really speak to seizure freedom. I'm not sure, Faith, perhaps you might know more than me on this.
Thank you, Melody. Yes, just to chip in, from my experience clinically during my training, we did see a few patients. Rasmussen's encephalitis was one of the biggest, the last patient that we saw, and he underwent anatomical hemispherectomy, and that really reduced his seizure frequency. And also the seizure burden with the parents, it also improved his quality of life, despite, yes, he was still more on the developmentally impaired aspect, but it really made a big difference on the families. And there was a study that was done by one of the postgraduate students, I'm sure she'll publish it soon, that it was a retrospective study, and they looked at pediatric patients, pediatric epilepsy surgery patients over time since 2000 up until 2021. So that's over a 20-year period. And they had about 60 patients, and you could say 20% of them underwent 7% underwent anatomical hemispherectomy, and then the remaining underwent a more modified peri-insular hemispherectomy. And the outcome did show about a 70% seizure reduced frequency, as well as severity and frequency. So yes, we do have Cape Town Red Cross Hospital, they do epilepsy surgery, and the outcomes clinically by experience, we do see a very positive outcome in terms of reduced seizure frequency, severity, overall quality of life, even their cognition improves with time. So yeah, I'm sure that there's also another paper that is in the woodworks. So hopefully it will come out soon.
Thanks, Faith.
Yeah.
And I apologize for always forgetting the children.
It actually drives us to put more out in pediatric epilepsy.
Yeah, it's good that you're here.
The next question is why the temporal lobe in particular? What happens post-surgery to the specific functions of areas removed? Example, when the hippocampus is removed and memory loss? Thank you.
Thank you. Yeah, that's a really good question. So indeed, some of the complaints that we get after epilepsy surgery is that some people complain of memory problems, and sometimes if it's on the dominant side, they complain of word finding difficulties. But interestingly, what's been found, again, with our study, we're going to speak to some of these things, is that the percentage of patients who actually complain about these memory problems, they tend to wear off over time. So say in the first couple of months, they might complain of this, but as we know, the brain is quite plastic and it makes waves. So what you don't want to do is a bilateral temporal lobectomy, but where you've done the one, the other is most likely to take over the function. So we found that over time, especially more longer term, we had, say, only about 20% of patients still complaining about memory problems. And we've those who may be complaining about memory problems had them even prior to epilepsy surgery. So brain plasticity does take a role, and those things actually tend to settle down. It's very important. That's why that pre-surgical evaluation is really important, because another thing that's a potential complication is mood disorders. So some patients might become depressed, some even develop psychosis. So really important to have the pre-evaluation and make sure that prior to surgery, you're not operating, say, on a patient with a severe mood disorder that might actually worsen after epilepsy surgery. So all those things have to be considered, and there must be ongoing support for patients. For this procedure as well, it's so not only about the epilepsy surgery itself, but it's about how it changes your life. So imagine this patient has lived for 20 years with epilepsy, and now they're cured. And that just changes all the dynamic from living as someone with epilepsy with this burden, and now you don't have the burden anymore. And all of a sudden you're expected to just bounce back into society. And that in itself can present with adjustment disorders. So there must be good support, and there must be good counseling both before and after the surgery.
Absolutely agreed. Yeah, the brain is an amazing organ. Neuroplasticity is it definitely comes into play in terms of the recovery. The next question is, can you comment why a percentage of seizure freedom from 1 year follow-up dropped from 70% class 1 and class 2 to 50% after 3 years of follow-up?
Thank you. Yeah, so I can't know the exact pathomechanisms, but what are some of the things that people speculate? So there's certain thoughts about why seizures come back. Could be firstly from the same area where you did the surgery. So when epilepsy surgery is done, it's an approximation as close as possible to what you think the epileptogenic, what we call the epileptogenic zone is. But we've come to understand that epilepsy is something we call a network disease. So it's not just because you've taken away, there's a lesion here, you've taken it away. That is not guaranteed that the other abnormal networks that have formed are still not existing. So when you take away perhaps the most active zone, there are thoughts that because especially patients who've had surgery, say 20 years, their brain has formed these abnormal networks. And so over time, maybe some of those networks that were more dormant because of that active area become awakened. And so then the person starts having seizures again. So that's the one thought. The other thought is that in patients, particularly those with hippocampal sclerosis, it's noted that over time, when you've got unilateral hippocampal sclerosis, over many years, that can actually become bilateral, where you've got bilateral temporal lobe epilepsy, but one side is more active than the other. So again, if you take away the active side over time, there is a chance that that other side might rekindle. So it's a complex issue that people are still trying to understand and still trying to investigate. But at this point, it's just thought that there must be some abnormal networks that have awakened now that you've like disconnected one area. So those are some of the thoughts to that. And I think that's why even with patients who undergo epilepsy surgery, in as much as we really want a cure, and that is where you are not having seizures and you're not taking medication, that's really our goal. But you find that for most patients, what happens is you're not having seizures, but you're taking a small dose of anti-seizure medication. And so it's also really important to counsel patients that sometimes they will be seizure-free, but not necessarily medication-free. But there are those, and there are those as well who it's not necessarily that they can't be medication-free, but you know, they've been on medication for 20 years, and just the thought of not being on any medication is quite scary to them, because having a seizure is really scary. So some patients continue, not necessarily that they have to, but I think as a safety net. So it's a complex thing and complex discussion, but what I think is encouraging as well is we need to remember that these patients who are going for epilepsy surgery, they had drug-resistant epilepsy. So they were having seizures despite being on medication. Mm-hmm. So now if half of them are not having seizures at all, I think we should consider that a win, actually.
Absolutely agreed. And even if it's a small modification, going from taking 4 anti-seizure medications to 1 anti-seizure medication, it does make a very big difference in these patients, because they're already burdened by having so many, like basically a bag full of anti-seizure medications. Yes. I agree. So the next comment and question, thank you for the presentation. I want to ask, after surgery, the anti-seizure medication will continue or stop? I think you indirectly already answered.
Perhaps I could talk to how the anti-seizure medication stops. So after surgery, our goal is to try and start reducing the medication. So generally, for the first 6 months after surgery, most people will leave the patient on the medication that they were on pre-surgery. But this will vary, of course. Sometimes some patients, the side effects were really bad, so you might start the wean a bit earlier. But generally speaking, for the first 6 months, we might leave them on the medications that we see if they're having any seizures or not. And then now we start this stepwise process of taking away medicine. So many of these, as you saw, were on at least 2. Mostly they're on 2 to 3 medications. So you identify which one would be the easiest to take away. So for example, lamotrigine wouldn't be one you would start with because of all the titration that needs to be done. So you would start off, say, with levetiracetam, you take that away slowly over weeks, then give it another month, and then you start taking away. So you'll find the weaning process can be like a year to even 2 years. And as I mentioned, often what will happen is probably at least for the first 2 years, you might leave the patient on a single low-dose medication. There are many factors to consider. How often was that person having seizures prior to surgery? How bad were the seizures? So say there were mild seizures, then it means that you can take that chance of reducing the medications quicker, as opposed to someone who used to get really bad tonic-clonic seizures. So it's patient dependent, but generally after we wait about 6 months and then we start a gradual wean of anti-seizure medication.
Yes, and just to add on that, what we also tend to do is we look back in the fold and also ask the patient, out of these 3 anti-seizure medications, which one was the most effective? And that one we always identify, okay, this one we shouldn't touch. Let's start with the one that was least effective. So that also aids in the weaning process. But yes, it does take quite some time. Minimum, in my experience, minimum it can even go up to a year to just slowly gradually wean up the anti-seizure medication. And the second question from Shinta is it necessary for EEG evaluation for the patient after surgery? Thank you.
Thanks. Yeah, that is an important question.
Mhm.
So, is it necessary? I wouldn't say it's necessary, but when do we do consider EEGs, particularly say when we're weaning. So EEG can be quite useful, especially say in patients who used to get nocturnal seizures. You may want to do an EEG before you wean, because if there's evidence of lots of activity of abnormal discharges on the EEG, that may make you a little apprehensive. But we should always remember that the EEG, it's a tool that we use in conjunction with the clinical presentation and what the presentation the person is presenting with. So we never make treatment decisions just on the EEG. Sometimes you can have some mild abnormalities, but that doesn't mean that you won't wean the patient. So I'll say it's not necessary, strictly speaking, and you really firstly have to go with your clinical presentation. But where you've got concerns, we do often do the EEG. And in this case, unless we are worried, say, about worsening seizure frequency, we'll often just use routine 20, 30-minute EEGs rather than putting them back on the long-term video EEG.
Absolutely. Clinical history is always very important. When you sit and talk to the patient or the caretaker or the parents, they will always tell you what exactly is going on. So you just need to just take the time and take a thorough before and after history. So the next question is stereo EEG used for epilepsy surgery?
Okay, thank you. Yes, so for some studies and in some programs, they have used routine EEG alone to make selections for epilepsy surgery. And this is particularly for temporal lobe, and even more specifically for anterior temporal, medial temporal lobe epilepsy. So it's been shown that doing, say, 2 to 3 stereo EEGs, which all give you a congruent finding. So say you do 3 EEGs and they're all showing the focus in the same region. Then you also have an MRI, which shows the appropriate side hippocampal sclerosis, that might be sufficient. So the thing with EEG as well, we need to remember that it's a very good tool, but not the most sensitive of tools. So every time you do the EEG, maybe you're getting about 50 to 60% chance that you detect an abnormality. And so the more EEGs you do, the higher your chance of finding an abnormality. But then again, that has a cap. So up to 3 EEGs, it does show that there is benefit. But beyond 3, when you do 4, 5, 6, the chances of finding an abnormality becomes lower. So 3 routine EEGs in an appropriate clinical history, and say you also have appropriate imaging, has been used in some programs for epilepsy surgery. And that's also been recommendations in lower resource settings where you carefully select such patients. They've got 3 abnormal EEGs, they've got an MRI or CT with hippocampal sclerosis, they've got the right clinical seizure semiology, then that has been used, yeah, for selection.
Okay, so 2 more. Are there ongoing efforts within the region to have public epilepsy surgery centers of excellence?
Thank you. I think that's why we're having this talk. I'm hoping that's what will happen. So I've come back to Zambia, and we've met up with some colleagues, like formed groups, surgeons who are interested, nurses, psychologists, and we are hoping to see how can we set up these epilepsy surgery programs in Cape Town. So when I was doing my clinical fellowship, I had the privilege at the adult side to be involved in setting up a public service epilepsy surgery program. So they have been doing epilepsy surgery ad hoc every now and again, but we've now, together with the team there, established a service, an epilepsy surgery service. And again, I shout out to Dr. Aisha Soni, who's literally took this up with her own efforts. And so there's that service in the adult side. The children's side, at Red Cross Hospital, where Dr. Faith Mosha was, they also have an epilepsy surgery program, and that's in the public sector. And so we've got such centers. We do have residents, particularly in Cape Town, who come from all areas of Africa. Like I came from Zambia, and they're offering training there. And I think places like Zambia those are things that I'm aspiring to. So I went to that center, I trained there, and now I'm trained. And so I should then hopefully develop programs for training. And this is what I was talking about, where you train within the region, someone goes back their country, they try and set up a program there, they start training, and it sprouts up from there. So I think that's the goal, and that's why we're having this talk, hoping that we can inspire more of us to do the same.
Absolutely agreed, Melody. I'm really happy that you had this talk to create awareness and, as you say, to try and evoke some inspiration and aspiration to others out there that epilepsy surgery is possible. You just need the right team and the right training to come together. Because if you look at child neurologists, Melody, they're basically, you could say about 57% of African countries don't have a child neurologist. That's a huge number. And then you have like about how many billion people like in Africa? And you just have like how many, there are about what, 47 child neurologists, you could say. So you could say, sorry, 324 neurologists. So you have about 50 per 500,000 people.
Yeah.
So that is a huge,
it is a huge
lack.
gap.
We need to together, we need to cover and just come together and say, okay, where do we need to start? The start is always, I believe the start is always a tough part, but once you start and get the ball rolling, it is possible. But it all starts by identifying that there is a problem and there is a possibility. How do we solve the problem?
Exactly. And it's, as I was mentioning as well, it's about us appreciating what are the biggest issues in our setting. So epilepsy or epilepsies are so broad and so wide. There are so many causes, so many ways to manage them. But if we identify what are the main issues in our setting, we've identified lots of patients post-trauma, post-infection, structural epilepsies. So is going the route of treating structural problems something that could solve in our setting? We are seeing more increase. I mean, we're very few neurologists, very few child neurologists, neurosurgeons, but the numbers are growing. So can we think about tailor-made programs that will actually address the issues that we are facing that are peculiar to us here in Africa? I think that's also really important.
There was the very interesting paper that was released last year by Prof. Holmes and a team looking into epilepsy surgery in Africa. And it highlights the burden, and it also highlights how we are slowly growing in numbers to try and create awareness and say, okay, the need is there. Let's go in that direction. So it's a really, hopefully, fingers crossed, that we're heading in the right direction.
Yeah, the future is bright. We have hope.
Okay, so the last question is, thank you for the insight presentation. Is there any suggested food supplement to be advisably taken after surgery?
Thank you for that question. So I don't think there's any evidence at this point for food that you need to take after epilepsy surgery. I mean, there are specialized epilepsy treatment that involve food like the ketogenic diet, but that's not necessarily a diet that you have to go on because you've had epilepsy surgery. So I think the simple answer is, at this time, there isn't any particular food. You can, as long as you have a healthy diet, just like any other person, then that's all that we recommend at the moment.
Okay, so that marks the end of our questions. I just had one interesting, you highlighted in terms of cerebral malaria with epilepsy. That is very interesting. And I was wondering, is there any like particular affinity or affinity of the malaria parasites invading that area, or is there?
So I mean, the one thing that has been closely associated, or let me say the two things, with temporal lobe epilepsy and mesotemporal sclerosis. One is febrile seizures, so a history of febrile seizures, and two is any meningitis or meningoencephalitis. So previous inflammation in the brain at some point in your life, and especially early on in childhood, has been associated with mesotemporal sclerosis. So I wonder if it's that specifically or it's the malaria itself. I mean, there's also been some studies which have shown an association between neurocysticercosis and mesotemporal sclerosis.
Yeah.
And so these are some of the things that we need to investigate, because cerebral malaria, neurocysticercosis, these are peculiar to our setting.
Yes.
So it's only us really who can answer if it's a direct relationship in terms of the pathogen itself, or it's the sequelae of that pathogen that then leads to these problems. At the moment, I think we're thinking it's more like because there was inflammation, then it's a cascade of events happened that led to mesotemporal sclerosis, and cerebral malaria just happens to be common. But I think I don't know at this point if there's a direct relationship. And that would be interesting too.
That would be interesting to explore, especially in our setting.
Yeah.
Thank you very much, Melody. We don't have any other questions. Thank you very much for a very insightful presentation.
Thanks, Faith. Always a pleasure. And thank you again for having me.
Thank you all for attending. And just to end off the webinar, so there'll be at the end of the webinar, I'd like to just highlight about the Global Health in Epilepsy Project database, which provides a registry of existing epilepsy projects throughout Africa, the Eastern Mediterranean, as well as in other regions. It identifies information such as project location, institutional partners, project scope, funding sources, and volunteer needs. The database is quick and easy to complete. By submitting information on your projects, you inform understanding of efforts that are occurring throughout the world to narrow the epilepsy treatment gap. The database will also provide you an opportunity to learn from others and to explore collaboration opportunities that might strengthen your own work as well as that of the sector. Furthermore, the database will allow people from different areas such as the government, academia, nonprofit, or philanthropy to learn about existing efforts while offering a means to engage. So on the next slide, please scan the QR code to receive your certificate. Also, there's a link in the chat below, in the chat box below to obtain your certificate. Otherwise, thank you and wishing you all a lovely evening or day. Thank you. Bye.
Bye.